the University of Minnesota. But in addition to that role, she also became board certified in child abuse pediatrics because it wasn't enough to just maintain certification in pediatrics. She needs to maintain certification in 3 things. So in terms of like her career path to that, you all must know her career path in terms of the fact that when she was initially doing critical care, she was at the University of Iowa from 1998 till 2007 when she joined our faculty. But then in 2012, she was like, I'm just not doing enough. I'm going to do that fellowship in child abuse pediatrics. So then she took that on as well, and she completed her fellowship. We talked yesterday, it was June 30th in 2014. Mm-hmm. She is now, of course, a board certified. We call it a CAP. This I just learned also from my staff yesterday. It surprised me. In addition to being critical care and a CAP, she's also been that best doctor. No CAP gets to be a best doctor. I mean, I'm never in those magazines listed as a best doctor anywhere. And she's been a best doctor multiple times in the Minnesota Monthly and best doctor in America. So I'm really excited to introduce her this morning as she switched hats from critical care over to child abuse pediatrics and does one of the most difficult topics as a grand rounds topic. So we're really excited to have her kick this off this morning. Thank you.
Thanks, Nancy. Okay, so I think I have this on. Am I good? You can hear me okay?
Did I turn mine off?
Yeah, I got it off. Okay. So good morning, everybody. So I picked this topic in particular because I think it blends well with critical care and child abuse, so I kind of can do both things. So I'm going to talk about head trauma, child abuse, different medical diagnoses, and doubt. I'm going to bring this all together, I hope. I have nothing to disclose. The things I'm going to talk about today is how peer-reviewed literature directs our medical evaluations of kids with head trauma. I'm going to demonstrate how we use our protocols here, working towards a medical diagnosis, and I hope to help people recognize the harm weak science has in our legal system. So, looking at the skepticism dial, if you will, if you can imagine one in your mind, and think about, as I go through this talk, where you are individually thinking about child abuse, what you think about the literature that's out there, what you hear in the news and so forth. Where are you on the skepticism dial about this? I would argue that doubt is very important. People write about this, doubt throughout history, how doubt moves our society forward out of the status quo onto something better. So I would say that having doubt in something is actually a good thing, but separating fake science from real science is really important, and I'm going to talk about that. So, just to have you think about some other things as we move forward, who do you think said this, and what year was it said? Basically, that subdural hemorrhages and retinal hemorrhages aren't evidence enough to support a shaking baby syndrome or a shaking mechanism of injury in an infant. And further, that doubt is increasing in our medical community over whether infants can be fatally injured through shaking. So think about who said that and what year. I'll tell you at the end. So the different parts of my talk, I'm going to go through a historical perspective, a clinical approach. I'm going to walk through 2 case presentations, both children I saw here. And then I'll end with evidence-based medicine versus, I didn't know what to call this, scientific conclusions without science or something like that. So, going back in time, this toddler was estimated to be 2 to 3 years of age. This toddler is known as Burial 519. This toddler was found in Kelis II Cemetery. Kelis II is located in Egypt. This cemetery was used in 50 to 450 AD. The anthropologist that found this skeleton, and at the time of this paper was published, they had evaluated about 700 skeletons, burials in this cemetery. This one was unusual because it had numerous fractures in different stages of healing. The clavicle fracture was acute. There was no healing to it. It probably occurred at the time the baby died or the infant died. There were 2 upper extremity fractures that both had about a week or 2 worth of callus healing, so relatively acute, 2 well-healed rib fractures, and 3 pelvic fractures. This toddler skeleton stood out, different from the other children that were found in this cemetery. They discussed that this toddler had some similarities with scurvy, but further they go on to hypothesize that this might be the oldest case of child physical abuse that they've discovered so far. So let's go forward in time just a bit to the 1860s in New York. It was 1866 that the American Society for the Prevention of Cruelty to Animals was actually founded. That predates 1875, which is when the Society for the Prevention of Cruelty to Children was founded. And then over the next 100 years or so, different physicians write about their experience and their observation about children who present to medical care or who have died with various different types of injuries. And they're trying to pull this information together as an individual writer, as physicians did, more so back then, about what they thought their observations were and what they meant. But it wasn't until 1962 that the Battered Child Syndrome was written by Dr. C. Henry Kemp and 2 co-authors. And this was the first time that they brought a lot of information together discussing the entity that was child physical abuse, directing physicians towards this diagnosis, how to evaluate children, how to deal with the families, how to report this information to authorities. So this was kind of a landmark study in caring for and assessing child physical abuse. And then going forward a little bit more, 2006, the American Academy of Pediatrics recognized child abuse pediatrics as its own subspecialty. And then the first boards were in 2009. So what happens when you now have a group of people that think about and work and research children who experience trauma of all types? Well, you can start to answer really simple questions because people are doing research in this area. So, for example, this relatively simple question: do short falls result in serious injury or death in young children? Relatively simple. So this little guy here, if he tumbled and his head fell 1.5 meters or 3 feet, what would happen to him? So a very large literature review was done, and in 7 points, I'm going to tell you that we know a lot more than we used to know. So first, looking at 2 caregiver studies, they looked at 2,750 children. This is the caregivers' recollection now. Collectively, these 2 articles state that short falls are common in young children, but severe injuries from short falls are rare. Next, we have 6 case series looking at 670 plus falls in an objective setting. An objective setting is like a hospital. So if a short fall happens in a hospital, those falls have not resulted in subdural hematoma or death. Next, 2 studies looking at short falls in children in daycare centers. Lots of children in daycare centers, licensed daycare centers. So again, kind of an objective setting again. Collectively, these 2 studies were able to state that children in licensed daycare centers rarely die from short falls. The next 2 bullet points are from the same study. They did something a little bit different in looking at the outcomes of short falls in children. They broke it down by how these falls were witnessed. So children that were well witnessed by 2 or more adults, or children that had a fall that were witnessed by nobody or maybe just one witness. They concluded that severe injuries and deaths are rare in short falls when they're witnessed by 2 or more adults. But ironically, the authors state, severe injuries and death are more common in short falls witnessed by a single adult. They go on to say that if a death occurs in an uncorroborated short fall and that history is accepted as valid or as fact, then a short fall appears to be more dangerous than a longer fall. Further, 2 prospective studies looked at 152 children, now prospective studies, and they also concluded that severe injuries or death resulting from short falls are rare events. So what does rare mean? We kind of come down to this one systematic review, a very large study looking at a lot of different types of evidence out in book chapters and in literature right now, and they come to a number of less than 1 death per 1 million children per year. That's what rare is. So we can go back to this child and we can say with fairly good certainty that this child might have, if he falls off this little toy, he might sustain a simple fracture, he might have a concussion, but it would be highly unlikely that he would sustain a life-threatening brain injury. So shifting more from simple falls and head injury towards abusive head trauma and shaking mechanism of injury, what do we call this? There are several different names that we see in the literature. I've mentioned battered child, shaken baby syndrome, inflicted head trauma, abusive head trauma. Shaken baby syndrome really seems to be a lightning rod, especially in the lay press and media. Historically, it comes from Dr. John Caffey, who is a pediatric radiologist. In 1946, he coined the phrase whiplash shaken baby syndrome. That's because he was trying to put together 2 findings that he saw in his patients, subdural hemorrhages and fractures of long bones, and he hypothesized that it was a shaking mechanism of injury that was causing both of these things. However, American Academy of Pediatrics is now recommending we use the term abusive head trauma. And the reason they suggest that is because it's more all-encompassing. When we use the term shaken baby syndrome, you kind of presume that you understand the mechanism that caused the injury in the child, and most of the time we have no idea exactly what the mechanism was unless it was observed by somebody. So they recommend using this term abusive head trauma because it would include a shaking mechanism of injury or shaking with impact against an object or an impact or contact injury alone. It would take all of those things into consideration. Just so we know what I'm talking about when we talk about a shaking mechanism of injury, I don't have a video to play or anything like that. I just want to talk through so we're all on the same page. This kind of caricature of an infant being shaken reminds us that the head is violently comes forward, the chin might come in contact with the infant's chest, the head is then thrown back, the back of the head may come close to touching the back of the upper thorax on the back, and this happens violently at 2 to 3 times per second for several seconds, and then it may reoccur if the baby is shaken again. And the type of injuries that we're interested in is what's happening in the brain when this happens and what happens to the spinal cord and the blood vessels around that area with this type of mechanism and force of injury. So we're unfortunately not like woodpeckers. They seem to do fine. Babies don't. So why are babies at risk? And when people talk about this diffuse mechanism of injury, this shaking mechanism, they're talking specifically about acceleration, deceleration, and rotational forces. That's a lot to say. We just say it's a diffuse mechanism of injury. But why are babies at risk for this? Well, they have a relatively large head and weak neck muscles. They have softer brain tissue because they are busy making myelin. They haven't made as much as an adult has. And they have a relatively flat skull base. So wouldn't this be great if all of our babies were born with this warning on their head that says, don't shake me, I'm at risk, but they're not. So How do we relate the injuries that we see with this mechanism of injury? There are three things that we look for in particular. Hope this has a, oh yeah, subdural hemorrhage. I have a lot of abbreviations in here, so I'm going to make sure everybody knows what I'm talking about. We focus on subdural hemorrhages because of the injury that happens at the basal cell layer of the dura, and I'm going to show you what that looks like in a minute. We worry about the development of retinal hemorrhages because of vitreoretinal traction in the eye. We also worry about diffuse axonal injury and cervical spine injury. So I'll go through each of the three of those with how we think this happens with this shaking mechanism of injury. First, to remind ourselves, this is the dural membrane. This is the superior sagittal sinus that it kind of envelops at the very apex of the head. It's not just a simple fibrous membrane. There are blood vessels that course through it, and there are arachnoid granulations that help drain CSF through it too. So it's not just a simple fibrous membrane. Further, it has three different cell layers. The bottom cell layer are these border dural cells. They are different from the other two cell layers in the dural membrane. They are flattened fibroblasts, they have no tight junctions, and they lack collagen. So therefore, this cell layer is actually the weakest cell layer of the dural membrane. Recall that the blood vessels course through this. So if this cell layer experiences shearing forces, it can kind of tear apart there, and you get a hemorrhage because the blood vessels coursing through there are not supported as well. Some people would rather subdural hemorrhages were renamed intradural hemorrhages because it really is within the dura that these hemorrhages develop, not underneath them. This is just to remind us that these subdural hemorrhages can collect quite a bit of blood, and they can create mass effect on the brain. So what's happening in the eye with this shaking mechanism of injury? The vitreous body in the eye does have attachments to the retina. Babies, for whatever reason, seem to have more attachments than older children or adults. And because of the different density with these shaking movements of the eye, the vitreous body can pull on the retina. And it's proposed that that's how the retinal hemorrhages occur with this type of mechanism of injury. And then just a little bit about what we think might be going on with axonal injury with this diffuse force that the brain experiences. Some people pathologists are looking at beta amyloid precursor protein. That's a protein that is expressed in nerves when they're injured, and it is present very quickly after a neuron is injured, within about a half hour or an hour. And it turns brown when you stain for it, and they can sometimes see transections of the neurons as demonstrated in this one here. So those are the mechanisms of injury that are proposed. But as a clinician, I would want to know, how do we bring all of this together? If I see a baby with subdural hemorrhages, retinal hemorrhages, and brain edema, how do I know it's the shaken mechanism that caused them? What other things do I need to think about in this infant that I'm seeing? So for example, how bleeding disorders might play a role in a baby that has a lot of blood in the head or in the eyes. What role does the birth process or CPR have on the development of retinal hemorrhages? Retinal hemorrhages have lots of etiologies. And then what evidence do we have that shaking actually causes the brain tissue injury? So I'll go through each of these three. So one question to ask: what is the probability that intracranial hemorrhage happens as a presenting symptom in the setting of an inherited bleeding disorder? So some people have done some calculations about this. They looked at the genetically transmitted bleeding disorders from a very large database that I believe it's at the CDC that they're collecting all this information. This is for the general population, the prevalence of each of these genetic disorders, and then the prevalence of an intracranial hemorrhage being a presenting symptom for each of these, and coming up with a probability. The probability for even common diseases like von Willebrand's disease is low. I wish I had an actual number, but they said low. I don't know what that is. And then you can kind of get an estimate for other genetically transmitted diseases. Again, this is for the general population. If there's a family history and a baby presents with an intracranial hemorrhage, that would change things significantly. What does the literature say about bleeding disorders and intracranial hemorrhage in infants then? This is a really important prospective study. These folks followed children over 10 years, collected data on just under 200 children, and they concluded that bleeding disorders can present in a manner that is clinically indistinguishable from abuse. So that's a really important point, and that will directly impact how we evaluate our children. Von Willebrand's disease, I mentioned that it's the most common genetically transmitted bleeding disorder. Combining the conclusions for 4 case reports and 1 case series for over 700 children, they collectively concluded that there's no scientific data to support the hypothesis that von Willebrand's disease is the cause of spontaneous intracranial hemorrhage in young, immobile children. But it very rarely can contribute to bleeding problems with minor head trauma. And then platelet disorders, congenital platelet disorders are very rare in and of themselves, and intracranial hemorrhage being the presenting finding for congenital platelet disorders is on the order of about 1% of those children. What do we know about retinal hemorrhages? One very large systematic review that distilled down to 134 articles plus 2 retrospective studies. Collectively, we can say with this information that retinal hemorrhages that are too numerous to count, multi-layered, and extend out to the ora serrata, meaning they extend out to the periphery of the retina, are highly specific for abusive head trauma. Other things that cause retinal hemorrhages do not look like this. And then a prospective study, 2 studies looking at over 200 healthy term newborns demonstrated that retinal hemorrhages just from being born are actually fairly common. About 35% of newborn infants have retinal hemorrhages that can be identified by an ophthalmologist. We also know from these studies that these retinal hemorrhages go away very quickly, and that if you have retinal hemorrhages that are being seen after the child is 1 month of age, very likely it is not due to just being born. And then a prospective study, another 2 studies combined, more than 200 patients looked at chest compressions and as the cause of retinal hemorrhages. Chest compressions, they concluded jointly, do not cause severe retinal hemorrhages. And when I mean severe, the very top bullet point, they do not cause retinal hemorrhages that look like that. You can, however, get retinal hemorrhages, a few scattered in the posterior pole with prolonged CPR. What do we know about brain tissue and spinal cord injury with the shaking mechanism of injury? Back to our beta amyloid precursor protein. One study that collected samples from 3 different institutions looked at different types of a pattern and concentration of this staining when infants, so 3 years of age and less, died from some type of brain injury. So they separated out traumatic brain injury from asphyxia, which could be positional asphyxia or drowning, or infectious causes. And they demonstrated that the pattern and the concentration of the beta amyloid precursor staining was different in the traumatic brain injuries. They were more concentrated in the midbrain down to the spinal cord. So hypothesizing that you might have an area of the brain that is more sensitive to injury with traumatic brain injury. Then looking more at the spinal cord using autopsy studies. 2 studies collectively looking at 47 autopsies concluded that cervical spine injury is a frequent but not universal finding in young children with fatal abusive head trauma, on the order of 70%. Spine fractures, though, are actually very rare. So 2 studies looking at 2,750 or more skeletal surveys found the prevalence of spine fractures to be quite rare. And I put an asterisk by one of these because one of these studies actually Dr. Nancy Harper was an author on. So important information. So how do we pull these clinical findings together? 2 systematic reviews concluded, the first one concluding that multiple subdurals over the convexity of the brain, intrahemispheric hemorrhages, posterior fossa subdural hemorrhages, hypoxic ischemic injury, and cerebral edema all are significantly associated with abusive head trauma in young children when they have no other history. One other finding that talks a little bit about clinical presentation. 14 studies, about half of the kids had abusive head trauma. They found that apnea, in particular, had a positive predictive value of 93%, and retinal hemorrhages had a positive predictive value of 71%, were the features most predictive of abusive head trauma. And then one more point to bring this particular part of the talk to a close, because it was unique. What this group did, they had a very large study, but one part of it had associated head trauma findings with confessions of the abusers. What they did in this particular type of their study is they had 45 head trauma victims with associated confessions, and they compared that to a subset, 39 children who were victims of accidental trauma. These 39 cases they pulled out specifically because they occurred in a public place and were well witnessed, because they wanted to completely separate the 2 groups of children that they were comparing. And they felt this confirmed the diagnostic value of subdural hemorrhages, severe retinal hemorrhages, as I've characterized them before, and the absence of signs of impact in differentiating between abusive head trauma and accidental injury. And this point about an absence sign of impact, again, gets towards shaking. This whole idea that shaking alone can fatally injure a child. So, to summarize the mechanism of injury, this diffuse mechanism of injury is associated with subdural hemorrhages, the retinal hemorrhages. There's some evidence towards diffuse axonal injury as well as cervical cord injuries. I didn't really talk much about impact injuries. Those are conceptually a little bit easier to understand. Obviously, we look for scalp injury, skull fractures, epidural hematoma, and brain contusions. And it's important not to forget about secondary injury in these kids. Apnea, as I've mentioned, is very important. Hypoxia and seizures, all of these have a negative impact on the outcome of the child, and we work clinically very hard to support the child to try to prevent any of these things. I've mentioned apnea again, just that it has a very high positive predictive value when it's found and associated with head injury and no other cause of the head injury. Positive predictive value for abuse. So, I have to stop and say at this point, I've covered a huge amount of published literature. However, not everybody is on kind of the same path on thinking that this is the mechanism of injury and abusive head trauma. And I will talk about one of these alternative hypotheses. It's called the Unifying Hypothesis. Dr. Geddes and colleagues wrote 3 papers. The first one, I'll call Geddes number 1. These are neuropathologists. They looked at children who died from abusive head trauma, compared them to children that died of other types of head injury. And they felt that diffuse axonal injury, again using the beta amyloid precursor protein staining, they felt that in the abusive head trauma kids that diffuse axonal injury was fairly uncommon. They did see it, but it was not as common as they thought it might be. Their second paper then found that actually cervical spine injury was more common. They kind of concluded that it was the cervical spine injury that was a cause of the apnea, and then the following hypoxic ischemic encephalopathy that they were seeing in these children. The third paper goes something like this. This is straight from their paper. Since diffuse axonal injury does not happen in abusive head trauma, severe acceleration-deceleration injury, therefore, does not happen in shaken injuries. That was their conclusion. They further then propose another hypothesis. So hypothesis A is kind of the more accepted hypothesis, the large body of literature that I just reviewed, suggesting that the injury can cause outward signs of trauma, it can cause apnea, and it can cause subdural hemorrhages and retinal bleeding. Their alternative unifying hypothesis is that the injury can cause outside signs of injury. It can cause apnea, hypoxia, brain swelling, and that causes the subdural hemorrhages and the retinal bleeding. The important difference here is that if you take out the injury, they suggest that hypoxia can cause the retinal hemorrhages and the subdural hemorrhages. So, as I mentioned before, it's good to have doubt in the status quo, and how do we analyze these things and find new, potentially helpful paths or ways to treat patients. The problem is, if you look at the papers, there are several flaws. The first two papers, the neuropathologists were not blinded to the patients. They were their own patients. They went back in their patient logs, found the patients, and evaluated their own patients. They were not blinded, although their findings were not too different from what other people might be finding currently. The third paper I found most difficult to understand how they came to their conclusion. Out of the 50 subjects that they used for that paper, 20 of them had neurohistological samples from fetal tissue as early as 18 weeks gestation. So in my mind, that's comparing apples and oranges. None of the other studies used fetal tissue to demonstrate anything. So I think it's important, but these are out there in peer-reviewed journals bringing up these alternative hypotheses. I'm going to take a break from the big literature review that I did, and I'm going to walk through two cases. First, this is one of many protocols that we have out there. They are drawn on the evidence-based literature that we have. They are focused on the age of the child, the developmental ability of the child, and they walk us through, if child abuse is in the differential diagnosis, then we have several things that we can do to evaluate the child in an all-encompassing way with the goal of coming up with a medical diagnosis. So I have two children, and I'm going to present them in parallel. You get a phone call from your emergency room colleague. Patient number 1, I have a 6-week-old infant. She's unresponsive and apneic. Patient number 2, I have a 5-week-old lethargic male who's had emesis. That's your history of presenting illness. You get more information on patient number 1. She was previously healthy. She had been feeding normally. The mom recalls walking through a doorway and bumping the baby's head on the doorway, but she seemed fine after that. That evening, there was a change in caregiver. Mom went to work. Dad took care of the baby. And the baby didn't seem right all night long. The baby was fussy. She didn't eat. The day of admission, that morning, she presented moaning and lethargic. Baby number 2, also previously healthy. This baby had a large cephalohematoma noted at birth. At 2 weeks of age, the baby was brought to their primary care because he had blood from his nose. At 4 weeks of age, this baby had a bruise on a wrist and a bruise on a knee, but was not taken to medical care at that time. A week later, on the day of admission, the baby's lethargic and has had 2 large volumes of yellow emesis. So those are our 2 sick babies that we're going to work through. This is baby number 1. I mentioned she was apneic, therefore she's intubated. Might be a little bit hard to see, but she has some petechiae in both of her ears. She's got a little bruise here, and she's got scalp swelling. Here is her head CT. She has significant hemorrhages throughout, subarachnoid hemorrhages. She has a large subdural hemorrhage over here, and she has signs of brain edema consistent with hypoxic ischemic encephalopathy. These are her retinal photographs. The ophthalmologist would say she has too numerous to count, multi-layered retinal hemorrhages in both eyes that extend out to the periphery on both of her eyes. Here's her MRI of her spine. First, I'll note she does have this focal area of swelling on her scalp that was also visible on physical exam and the head CT, but you can see it well here. This red bar right here highlights the epidural hemorrhage that's around her spinal cord, starting at about C2 or C7 and extending down. So what do we have? She has scalp edema, that focal area of swelling, and ear petechiae. It's suggestive of an impact type of trauma. She has subarachnoid hemorrhage, subdural hemorrhage, too numerous to count retinal hemorrhages, and an epidural hemorrhage of her spine. So I would suppose that she has evidence of diffuse and also focal contact impact mechanism of injury. We obviously need to complete a child abuse workup that would include a coagulation evaluation because she has so much blood in her head and her eyes. Baby number 2. This little guy presented with bruising on his knee, and this fairly large bruise here, it's kind of hard to tell, but this is his right flank. His legs extend down here and his head is up here. This bruise, not only visible, it was actually palpable. If you felt it, it actually had some depth to it. Here is his head CT. He has 2 intraparenchymal hemorrhages, one way down low, one in the right frontal area, and you can see this very large cephalohematoma. The rest of his brain looked okay, but 2 large intraparenchymal head bleeds. The mechanism of injury. Bruising makes you think of trauma. Intraparenchymal hemorrhage. Well, that's kind of different from all the abusive head trauma hemorrhages that we were talking about. It makes you think of trauma, certainly, but could there be a medical condition going on? And also this history of nosebleeds and a cephalohematoma, also bleeding problems. Could something else be going on? Both babies get a full child physical abuse evaluation, including baby number 2, was seen by the ophthalmologist and had a normal retinal exam. Baby number 1, essentially, this is the upper limit of normal. You would argue 1.17 is an upper limit normal for INR. The rest of the coagulation factors completely normal. Baby number 2's INR, I think you can say, is definitely out. This is abnormal for a 5-week-old baby. We send off one other lab. This gamma carboxy prothrombin was quite elevated. This is also known as PIVKA, which is the protein induced by vitamin K deficiency. So we make medical diagnoses. Baby number 1, we diagnose with abusive head trauma. About a week into the hospital stay, the father confessed. He confessed to being very frustrated with the baby during a diaper change in the middle of the night. He couldn't get the baby's clothes off. He very forcefully, violently went to rip the clothes off. The baby came with him, flew across the bed, hit the footboard of the bed, and then dropped to the floor. Baby stopped crying and just kind of whimpered all night long. And he didn't tell anybody until about a week into the hospital stay. Baby number 2, we diagnosed with late vitamin K deficiency bleeding. And the parents elected not to give vitamin K at the time the baby was born. We obviously knew that. I wasn't going to say that at the beginning. But still, we did go through our normal steps. Just a side note, once I felt like we had good rapport with the family, and without putting on more guilt than they already had, I asked them, and CPS also asked them, why did you make that decision? You didn't choose that for your first child. Why did you choose it for your second child not to give vitamin K? So this is for all of us to learn, because I had no idea. This is why. They're smart people. They went online, they pulled the package insert for vitamin K, and what does it say? Blah, 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 blah. Fatalities, hypersensitivity, anaphylaxis, shock, cardiac, respiratory arrest. Sounds awful. This was not written for newborn babies, though. This was written to alert physicians when they have an adult who's on anticoagulation, they have to quickly reverse it because you need to take the adult to surgery. That's what this was written for, not babies. In the world's literature, there is maybe one baby that anaphylaxed to vitamin K in one case report in Turkey in 2014 of the millions of babies that have had vitamin K, and they chose not to give it. So this is on the internet, guys. We just have to be out there and take care of our patients and our families. So where do we go from here? Our hope is to continue to build clinical pathways that are based on strong evidence-based medicine, so we treat our patients appropriately and evaluate them appropriately. In doing so, we hope to avoid bias, and we hope to get better about diagnosing medical conditions that can be confused with child abuse. But this is an uphill battle, and here is why. Remember those statements I said at the very beginning of the talk, the people that didn't feel that subdural hemorrhages and retinal hemorrhages would strongly support a mechanism of shaking, and that the medical literature out there now is putting more doubt in this mechanism of injury. This was in 2011. Justices Ginsburg, Sotomayor, and Breyer were the 3 dissenting justices on a court case of an infant who died, people believe, because of a shaking mechanism of injury. How can this happen? Well, I don't know exactly how that happened, but here is one example. This is information from a journal that's very easily downloadable from the internet. It's the Western Journal of Emergency Medicine, written by an adult emergency medicine physician, referencing some of the things that I've presented in this talk. And he talks about, in 2009, the American Academy of Pediatrics set out to rebrand abusive head trauma, or shaken baby syndrome, and now we call it abusive head trauma. The reason we have to do this is because we need more clarity in the courtroom. And further, that this term deserves more scrutiny, and it appears to acknowledge that the shaking mechanism of injury is no longer thought sufficient to account for the resulting hypothesis. This is out there in the literature. If you pull the American Academy of Pediatrics statement on why they did this, that is not why they did it. As I said before, they wanted something to be all-encompassing that would include shaking, but also shaking with impact. So anyway, they tried to pick a term that was more inclusive and not confusing. But people are out there purposefully confusing it in the literature. So when these 3 justices in the Supreme Court were confused about the literature, the response of the medical community was 2 very large pieces of literature. Collectively, in my mind, this is a 300-page book report on abusive head trauma, if you look at both of these. They wrote these specifically for the people, jurors, or not jurors, lawyers and judges to understand this enormous body of literature out there in its entirety, including alternative hypotheses and grading the pieces of medical literature that are out there on their scientific validity. Was the study done well? Was it not? Using the typical grading systems that we're used to. They're called Daubert 1 and Daubert 2, sort of colloquially. So what is a Daubert analysis? Who was Daubert? Well, I don't know who Daubert was, but basically in 1999, in a case that didn't include children, didn't include child abuse at all, a standard was set forth by the U.S. Supreme Court, and it stated that trial judges needed to be gatekeepers. They needed to be gatekeepers, only allowing expert witness and expert testimony into their courtrooms when it is about scientific evidence or methodology that is of the highest standard. It's scientifically valid. It's accepted by the majority of the scientific community out there. So their job now are to be gatekeepers. That's why they wrote those two huge book reports, essentially on abusive head trauma. Minnesota has its own version of the Daubert standard. All states have some version, more or less, of it. So we have something that our courts are supposed to use. So that is my conclusion. This work is hard, it's time consuming, but it is incredibly important that we get our medical diagnoses right for our patients and for our families. Research has to be of the highest quality, and the reason is because this work has far-reaching consequences. And I'll stop there and I'll take any questions.
Thank you, Carrie. That was really terrific. I would like you to comment on the two cases you presented. The people that saw those babies were concerned about child abuse, and they called you. One of them had it, and one of them didn't. And I want you to comment on the appropriateness of primary care providers and emergency physicians only having to have the suspicion and contacting you.
Yeah, so I think that's a great question. I think my opinion is the more if the thought crosses your mind that physical abuse or neglect or whatever type of abuse is in the differential diagnosis, it is best not to keep it to yourself, have a conversation. I think we are trying to be very appropriate with our evaluations. I don't think we want to say that every child that somebody thinks might have child abuse is going to rush off and get a head CT and all of this other huge workup. There are things, what we're trying to do now, obviously in the two babies that I presented, when you're an immobile child and you come in and you have these injuries without a good explanation, you deserve a workup. Change the age, though, and make it a 2-year-old that is witnessed by one person to have a certain fall. The radiologic findings make sense with the mechanism of injury, and there are no other concerns, there's no delay in care. That might just deserve a phone consultation and quick note in the chart saying, we've looked at everything. I frequently, what I'm finding I like to do even better is when I hear about the child, the first place I go is radiology. Because we can look at the exams together. If it's a fracture, for example, we can look at the fracture. We can talk through the mechanism. I already have an idea in my head about what the facts are before I even go see the child. And then we can put it all together. Some of these things just need a note in the chart saying, yep, I agree, the mechanism makes sense with everything you're seeing, we're done. So we're trying to be very supportive, and just not always saying everybody has to have child abuse, if that makes sense.
Carrie, I missed the punchline. What was the Daubert analysis conclusions?
Well, so there's no conclusion. What they set out to do is review critically all of the literature that is out there to help people understand valid scientific literature that's out there and their conclusions. So, for example, the literature review for the shortfalls and the 7 bullet points, that is straight out of Daubert Part 2. They pull all this information in there and they say, they have gone through these pieces of literature, they've graded them with their scientific validity, and they write these conclusions. So it's not their author's conclusion, it's the literature's conclusion. And they tried to be, I think, as unbiased as possible, although I know a lot of their names and they're child abuse pediatricians. And this is what they do, they pore over the literature. One physician in Texas, he gets paid to pore over the literature. That's his job. So maybe there is some bias there in how they would say, one piece of information is scientifically, well done. The methodology was the best that you can do, and other pieces are not. And maybe they're biased there, but I think they're trying not to be. So they didn't have a conclusion other than these are the facts.
And their comment on the Getty's series?
Their comment on the Getty series was kind of, as I stated, they feel that while some things probably are very in line with what other people are finding who probably are doing similar experience, although with a stronger methodology with respect to where they're finding more or less diffuse axonal injury. Some people find more, some people find less. Makes sense because we don't know exactly the mechanism of injury of some of these kids. I think it makes sense. They're finding more injury in the spinal cord. Other people are finding that too. But this whole idea that hypoxia is a primary cause of the subdurals and the retinal hemorrhages, I don't think that holds water. And it was a poor study. I mean, I don't think you can draw the same conclusions that they drew from their information. And that's what the Daubert analysis or the papers would say as well.
Thank you.
Carrie, I guess for some of us, like in nephrology, one of our main concerns isn't always physical trauma, but the trauma of neglect, medical neglect. We, for example, just had a kid who came in he has end stage, he had a hemoglobin of 5, and he was, pretty lethargic and not doing well. He was, and usually they have some hyperkalemia, severe metabolic acidosis, and medicine has gotten better, so we can save these kids. But, in this case, the kid wasn't getting his EPO, his feeds and his whole schedule for all of his medications wasn't being adhered to. But we've often, called Child Protective Services, and, usually there has to be some type of visible harm before anything is done, because we can't get them to understand that, hyperkalemia, the kid could just drop dead and you can do absolutely nothing. So for me, those are some of the harder cases, because we have to send this kid back into the same home because there's no visible harm. So right. I'm not sure what your recommendation would be to do with these kids, parents, and...
Yeah, those cases are really hard. And I think it's, sometimes I think our group can help in translating all of that information so that CPS understands it. I think there is sort of a language we understand and there's a language that they understand. And so sometimes we can help bridge that gap a little bit. I think, so it's understanding what the barriers are that the family can't meet and how dangerous it is to leave that child in that situation and spelling that out for them. I think they have an incredibly hard job because we know there are not enough medical foster families out there willing to take these kids. So I think we don't always have good options. And so my guess is they're weighing things that we don't even, back and forth, that we don't even understand. But getting the language correct, translating the medical language into something that they can understand so they can kind of put it in their boxes is helpful. But again, those are hard cases.
I mean, because, I'm a shy person, so I usually don't say things like, the baby could have died, we saved the baby's life. And even those things are not enough. Yeah. And so it is very, very frustrating because you're sending a kid back into a dangerous, unsafe place, but you just can't prove it.
Right. Other than to tell them that. Just want to make sure you know.
We could have dead babies.
Right. Right.
Hi, Carrie. Thank you. So can you talk a little bit about this role that we as physicians have as investigating the cause of head trauma and determining whether we believe it to be a criminal activity or in our role as physicians and healing and supporting.
Yeah.
And how does that impact whether somebody shows up in the emergency department in a timely way or in the hospital in a timely way or not?
So so our job is, as physicians, we make medical diagnoses. We're not investigators. We have people that we work with that are investigators. And so what I tell people, I think, for example, one of my critical care colleagues had a baby admitted not too long ago, and the question was, what do I tell the family? And my answer was, you tell the family exactly what you would always tell them. Tell them what the diagnosis, what the type of brain injury you see. Show them the scans. Be as open as you can. You don't know who the perpetrator is. And the non-perpetrating adult doesn't know either, really. So we have to be very open and unbiased with these families. What I would avoid doing, though, is offering mechanisms of injuries to these families. So don't offer possibilities because they're going to rack their brain and think, well, how can I make this fit together, especially the non-perpetrating person, adult that's standing there. But be very open with the medical diagnoses, be upfront with what you think the potential is for the child. The worst case scenario is that we get these head injured kids in that you think is ultimately it's going to be fatal. We have to have these conversations. We have to be very open with them, but don't offer, well, did anybody shake the baby? Did anybody leave that for the investigators to do? Just talk about what you're seeing in the medical diagnoses would be my suggestion, because we are not investigators. We work alongside them, and sometimes they don't like what we can tell them and not. But that's not our job, if that's helpful.
Gary, thanks. That was really outstanding. My question is really pertains to prevalence of these types of injuries and the potential role or impact of public awareness campaigns, programs to prevent, since these are preventable injuries, and how effective those are. Are there other things that we should be thinking about or doing with new parents and prenatal programs to hopefully prevent these types of occurrences in the future?
No, that's great, because I do think, I mean, prevention is really where it's at, honestly, and I am not an expert in that area, but what I will tell you is that in the newborn nursery, educating families goes only so far, because as you saw in one of these, and I said it was the father of the baby, I think it was, that injured that one baby so badly, but frequently it's a boyfriend, and it may not even be the father of the child. And how do you get information out to that person? And I know, and Nancy, you might know more about this, but there's a program, I think it's Cindy's program, where they were actually sending babies home with books. These are books to read to your babies. But they're books for the boyfriend to read to the baby that tells them, don't shake the baby. I mean, in a nice way. That's what they're trying to get information out into the home that may be chaotic, that may have other caregivers. How do you get that information out there to those people that end up being the perpetrators? And that's really the hard thing. And they are trying other outreach programs where we have families that are in need, and having nurses go out to the home to make sure that kids and families get off to the right start so they can continue to provide this information. There's a huge effort that I don't know all of that's out there that is trying to get this information out in the home, not even just in the newborn nursery before the kids get home, because you're going to miss all those people that come in later. But that's where the effort has to be. We need a warning sign on the head. Onesies? Okay. Thanks, guys.
You have been disconnected from the meeting.